Welcome to the Tobacco Online Policy Seminary, TOPS. Thank you for joining us today. I am Luis Zavala Arciniega, a research associate at the University of Yale. TOPS is organized by Mike Pesco at the University of Missouri, C. Shan at the Ohio State University, Michael Darden at Johns Hopkins University, Jamie Harman Boyce at University of Massachusetts Amherst, and Justin White at Boston University. The seminar will be 1 hour with questions from the moderator and discussion. The audience may post questions and comments in the Q&A panel, and the moderator will draw from these questions and comments in conversation with the presenter. Please review the guidelines on tobaccopolicy.org for acceptable questions. Please keep the questions professional and related to the research being discussed. Questions that meet the seminar series guidelines will be shared with the presenter afterwards, even if they are not read aloud. Your questions are very much appreciated. This presentation is being video recorded and will be made available along with presentation slides on the TOPS website, tobaccopolicy.org. I will turn the presentation over to today's moderator, Jamie Harman Boyce from the University of Massachusetts Amherst, to introduce our speaker.
Thanks so much. So today we continue our winter season with a single paper presentation by Bingjin Xue entitled The Impact of E-Cigarette Regulations on Birth Outcomes. This presentation was selected via a competitive review process by submission through the TOPS website. Bingjin Xue is an assistant professor of economics at the University of New Hampshire. His current research focuses on the intersection of policy evaluation and health inequality. Dr. Andy Wang, a visiting professor of economics at St. Lawrence University, is a co-author of the study and will answer select questions in the Q&A. Dr. Xue, thank you so much for presenting for us today.
Thank you, Jamie. So thanks for having me. So I'm going to share my screen. Give me 1 sec. All right, so Jamie, can you see my screen?
I can, it looks great.
All right, perfect. Thank you everyone for coming. So today we're going to present our study on the impact of e-cigarette policies and regulations on birth outcomes. I'm Bingjin Xue from the University of New Hampshire, and my co-author Andy Wang is also here. He's going to help answering some Q&A questions. So before we start the introduction of our research, I want to start with some motivations and anecdotal facts. So my friend Andy, who is here, so he used to be a user of both combustible cigarette and e-cigarette, but he stopped doing so once his wife gets pregnant. And then part of the reason is so his wife demanded him to. So his wife is a strong supporter of all the e-cigarette regulations. Well, she claims that those e-cigarette policies, so they're helping improving the birth outcomes. And this is because e-cigarettes, they're also harmful. They contain nicotine, and then also they emit aerosols. And then as economists, Andy and I immediately thought, wait a minute, there could be a substitution effect, right? And the idea is if you ban e-cigarettes, then people may switch to using combustible cigarettes, which can be more harmful. So we decided to look at the effect of different e-cigarette policies on birth outcomes. And that's our motivation. So we start our disclosure slides. So the authors, me and Andy, we have not received any funding for this paper or any other tobacco-related funding in the past 10 years. So we start our study by looking into the statistics. So there is a rising prevalence of e-cigarette use in the United States. In 2023, according to CDC, 6.5% of adults reported current e-cigarette use. That's 7.6% among men and 5.5% among women. So we use these statistics. We try to show that maybe e-cigarette policies, they can affect a sizable population. So the distribution of e-cigarette usage varies by age groups. Usage among ages 21 to 24 is the highest, that reached 15.5% in 2023, while other adult groups, ages from 18 to 49, they also show high prevalence rate. So if you are familiar with the fertility literature, you may realize that this age group coincides the reproductive age. So we are trying to say that e-cigarette policies, they may have an effect on pregnant population. All right, so next we zoom into e-cigarette usage during pregnancy. There is a high prevalence during pregnancy. So people who use e-cigarette during pregnancy is roughly 7% globally. And this rate is high when including pre-pregnancy use. So a lot of people, when during pregnancy, they are going to cease smoking. They are going to switch to either the NRT, which is nicotine replacement therapy, or they are going to switch e-cigarettes as a way to cease smoking. So a survey conducted by multiple authors, they conclude that many pregnant women, they perceive vaping as safer than smoking. There are a lot of potential risks and potential benefits associated with e-cigarette use during pregnancy. So first, we talk about direct effect. So e-cigarettes, although they are perceived safer, they do contain nicotine, and also they give people exposure to aerosols, so it can be harmful to the baby and the moms. However, there is no consensus on whether vaping is safer or smoking is safer during pregnancy. Another channel through which birth outcome may be affected by e-cigarette policies is through secondhand smokes. So Schilling and co-authors, they find that there is a high frequency of household exposure to nicotine from partners. However, on the other hand, e-cigarette utilization may have some potential benefits, and this is through the substitution effect. So for some, vaping supports cessation, reduction of cigarette use, and it also supports them quitting, and quitting smoking improves outcomes. So there can be both channels of the effects when we analyze the effect of e-cigarette policies. So our study focuses on 4 state-level e-cigarette regulations. They are indoor vaping restrictions, minimum legal sales age. We consider 18 and plus threshold, especially. And then we also consider e-cigarette tax. We consider e-cigarette retail licensure laws. So we go through them one by one. So indoor vaping restrictions prohibit e-cigarette use in indoor public spaces. And usually those public places considers workplaces, restaurants, and bars. In our study, we consider an either-or relationship. So we consider an e-cigarette policy that ban e-cigarette use in either workplaces or restaurant or bars. And these indoor vaping restrictions are often integrated into clean indoor air laws, or we call it smoke-free air laws. The second policy we consider is minimum legal sales age. The age threshold varies by states, but most of them are 18, 19, and 21. Many states adopted the 21 threshold prior to the federal tobacco 21 law, which is effective in December 2019. In our study, we focus on 19 plus threshold. We don't focus on 19, and we're going to give you the reasons in the next slides. So e-cigarette policies. So in our study, we consider both volume-based e-cigarette taxes and price-based e-cigarette taxes. The last policy we consider in this study is e-cigarette retail licensure laws. So these licensure laws usually require licenses if you want to sell e-cigarettes over the counter or through a vendor machine. So there are some other e-cigarette policies that is not considered or analyzed in our study. This include flavor bans. So the earliest flavor ban, so we're talking about the state level flavor bans. The earliest of them is in fall 2019. which is roughly the end of our study window. So that's one reason why we don't consider them. And another reason is because of our study design. So if we analyze flavor band, then it will make our empirical strategy more challenging. So we're going to talk about that later. So the second policy we didn't consider is the federal minimum legal sales age, which sets the age threshold at 18 in August 2016. We don't consider this. Again, the first reason is this is a nationwide implementation, which limits cross-state variation and challenges our identification. Another reason is we are analyzing the effect on reproductive age population. And there is it's a very small exposure share for births for those who are under 18. In our data, we only have 2.3% of live births, which are moms under age 18. So we ignored minimum legal sales age, which sets the age threshold at 18. We also ignored federal tobacco 21 law because, again, those laws are at the end of our study window. All right, so on this slide, I show you a regulation rollout over time. On the x-axis, we have the year quarters. On the y-axis, we show the cumulative number of states with a certain type of e-cigarette regulation in effect. So all the dates in this chart are effective dates. And we use different colors to show different policies we consider in this study. That includes the blue for the minimum legal sales age, the red for licensure, and then we have the light blue for indoor restrictions, and then the yellow curve is for taxes. So from this figure, we have two takeaways. The first takeaway is, so roughly all states, they start their first policy in 2010. The second observation is there are increasing number of states adopt different policies. And then there is no strong preference of one policy over the other. And then you can see there's a spike in 2020, and that is the federal tobacco 21 law. All right, so, and then we talk about the literature, and then we think about the potential theoretical framework, how e-cigarette policy can affect birth outcomes. So in the economic literature, so from the theory perspective, there can be two possible effects. The first effect is what we call the substitution effect, which means if you restrict e-cigarette, it will definitely curb vaping, but it can also increase smoking or initiation. So this substitution effect is actually evidenced in multiple studies. The second potential theoretical channel is the gateway effect, which means a lot of people, so they started using e-cigarette, but then this utilization can introduce them to more harmful substance, including smoking and also substance use. Well, another theory is e-cigarette policies can change people's norms and perceptions. So home and public restrictions can strengthen anti-nicotine norms, and taxes can also increase perceived risk of nicotine. So what is the research gap that we're trying to fill? There are a few studies examining pregnant population or examine the downstream birth outcomes, and even fewer studies handle staggered state policy adoption timing and policy bundling. And those are the research gaps we are trying to fill in this study. All right, so the main research question, how do different e-cigarette regulations affect birth outcomes? So we are analyzing 4 different policies: indoor vaping restrictions, minimum legal sales age, 18 plus, and taxes and e-cigarette retail licensure laws. We look at 4 birth outcomes. So all those birth outcomes are birth outcome rate. We examine preterm birth, low birth weight, and also very low birth weight and infant mortality. Those are the 4 main outcomes we examine in this study. Next, we move on to the empirical method we used. So overall, we are going to use this difference in difference design. which means we compare treated states with the never treated states. And then if we see after the e-cigarette policy, there is a change in trend, then we are saying there can be some effect due to the e-cigarette policy. However, recent literature on DID identified some key challenges. The first challenge is staggered adoption. So that means if different states, they adopt the policy in different years or different points in time, and if those effects, they vary over time, then a canonical two-way fixed effect estimator can give you biased result. Or in other words, there can be some forbidden comparison. The forbidden comparison comes from comparing a late adopter to an early adopter. So what is the solution? So in our study, we used Callaway and Santana's DID estimator. What they do is very intuitive. So they are going to eliminate the impact of the forbidden comparison. They consider cohort-specific average treatment effect on the treated, and then we're only aggregating the allowed comparisons. So that is the key idea of identification. And we have a slide, which is from the Goodman-Bacon paper about DID, but given the time, I'm going to skip this slide. So next, we talk about the second challenge of identification, which is policy bundling. The idea is this. The e-cigarette policies, they rarely arrive alone. States often adopt multiple e-cigarette policies in close succession. So in our scenario, we have 4 policies, and we observe that multiple states, they adopt multiple policies at the same time, or they adopt the same policy about the same time. So here, I'm going to present 2 figures to give you some evidence of policy bundling. The first figure is a correlation coefficient matrix. So the x and the y-axis, I show you 4 different policies. Those are indicator variables, indicating whether a state has a specific policy in effect in that time. So here we have 2 observations. Number 1, if you look at the correlation coefficient, all of them are positive, which means if a state adopts one policy, they're more likely to adopt another policy. Another observation is this correlation can be extremely high. For minimum legal safe age and indoor vaping restrictions, we have this coefficient as high as 0.55, which means they nearly adopt the policy at the same time. The second observation is from this stacked bar chart. So in this stacked bar chart, on the x-axis, I still give you the timeline. On the y-axis, I give you the number of states. So this stacked bar chart tells you how many states have multiple policies at the same time. So for example, if you look at this yellow band, it tells you the number of states with exactly one policy in effect at that time. And then if you look at this blue bar chart, then it tells you the number of states with all 4 policies in effect during that time. So we have, again, 2 takeaways. The first takeaway is you can see that the state with only one policy, the number of states really goes down since 2017. So if you examine this period of time, you really need to worry about policy bundling. The second observation is since 2015, we observe the start of this red stacked bar, and then you observe this blue stacked bar chart. So they tell you that so starting in 2015, there are more states with at least 3 policies in effect. So that gives us challenge in identification. So how do we isolate the effect of a single policy? The idea is this. We're going to identify the first e-cigarette policy enacted by a single state. So for example, if a state enacted tax first, then we're going to label this state as a tax state. And then we're going to truncate that state's series at the date a second policy became active. So basically, we're going to limit the window to where the state only have one policy in effect. And that's how we isolate the effect of different policies. And we're using this CSDID estimator, which allows us to compare cleanly with the never treated states. So when we compare our treatment state, we're not comparing with the other treatment states. We're only comparing with the never treated states, the states that have never enacted any e-cigarette policy during our study period, which is 2005 to 2019. All right, so the next slide gives you what I call the identification window. So in this figure, you can see different color bar. They give you the first policy of each state. So for example, if you see a red bar, then that tells you the first policy of that state is minimum legal sales age. And if you see this green bar, it tells you the first policy of that state is e-cigarette licensure law. And then when you see the green bar, that tells you that the state already have a second policy in effect. So for some states, they enact their first policy at the same time as their second policy. So that's when you see a green bar at the very beginning. All right, so that's our key identification idea. I'm going to pause here to answer audience questions.
Sorry, my Zoom paused for a second, but thank you so much for that. Before we get to audience questions, please do keep bringing them in. I'm going to hand over to our discussant. So our discussant today is Dr. Michael Cooper, a postdoctoral scholar from the University of California, San Diego. He's published research on the effect of indoor e-cigarette bans on birth outcomes. Over to you, Dr. Cooper.
Thank you. So my first clarifying question is that you just mentioned that only never treated states are used as the comparison control group, and that leaves me wondering about pre-treatment states, if they're used as a comparison, and specifically, so looking at this graph you have, if you look at California, they go from zero policies to immediately multiple policies and then get truncated out of the sample. So is California serving as a control group or helping with identification somehow?
Thanks for the question. This is actually very important to our identification strategy. So we are using the never treated state as control only. So for example, California, that is not part of the control. And
Okay.
then, so we have 14 control states without any policy until tobacco 21.
Okay, got it. And then a couple clarifying questions. So these two questions are both basically, are your policies just going to be analyzed as indicators, like they're either on or off? Because I was thinking about e-cigarette taxes, they have different types. They have based on liquid or based on the price, and different levels, how strong is the tax?
Yep. So that's again another very good question, and that's actually our next step.
Ah,
So for now, we are considering an indicator variable. So it's 0, 1, and then once they switch on, they always stay on. So as far as I know, so when I examine, so our data come from the CDC state dataset, and then I examine that dataset in detail. We don't identify any state that switch back to control. So that's really give us the a very reassuring policy identification idea. And then in the future, we're going to try the continuous DID to identify the intensive margin of maybe the effect of tax. But maybe for minimum legal sales age, we don't see the benefit of using a continuous DID measure.
yeah. And speaking of the minimum, the age restrictions,
Yep.
I was just thinking that, uh, they only apply to a very small number of mothers. They apply to mothers that are, 18 to 20 or so. But if you just have this very basic indicator that turns on for all the mothers, you might be kind of washing out the effects on this very small subpopulation.
Yeah, that makes sense. So we're going to do some sub-sample analysis, but we're not going to present those results today. But definitely we're going to look at different age groups, different moms age groups. And then
Right.
hopefully we're going to see some effect for moms who are young. But then we'll see. We haven't done that part yet.
Okay, got it. And I just have one more comment before turning it back to you, which is that it's kind of a bigger, vague comment, which is that you're kind of, I just wonder if you're throwing out a lot of useful identifying variation in your data by truncating these states out. You know, these are a lot of useful states that are implementing multiple policies.
Yep.
And you end up comparing totally unregulated states like Florida and Texas to states that are very lightly regulated with only one policy. And then you're kind of throwing out the data from the heavy regulation states like California, like we talked about. So I
Yep.
just wonder if you considered any other estimators that could account for your two problems that you've been bringing up without throwing out so much data. With the caveat that this is very clean, what you're doing. This is a great way to isolate one policy at a time.
Yeah. So that's actually another next step we are considering. So for now, we are only trying to identify a very clean first policy effect. And then the next step is we are going to, based on the first policy, we want to analyze what's the effect of additional policies. And then we're going to try to build one model to estimate. So like you said, we're going to take advantage of um, all the variations. We build one model to analyze the effects of all policies. But then in that case, we are going to contaminate this estimator. So there is a trade-off. So we can definitely use maybe one CSDID will where we're going to include some dummy variables for the other policies, and then we can include all states. So that will be one of our robustness check.
Great, that makes sense. That's all I have for this part.
Thank
Thanks.
you.
Wonderful. Thank you. I think Andy is doing an amazing job answering audience questions. So I think go ahead and continue with the presentation. Audience, please do keep those questions coming in.
All right. Thank you so much, Jamie. So I will continue. So we move on to the data section, and then we're going to talk about or revisit our identification strategy and then show our preliminary findings. So the data we use are from the CDC Vital Statistics, restricted use birth certificate data. The sample we consider are 2005 from the first quarter to the last quarter of 2019. And we have county by culture panel. So we can analyze our data at county by year level as well. And then our result for now is quite consistent. So the outcome we considered are preterm birth rate, and then we also have low birth weight, very low birth weight, and infant mortality rate. We also consider some smoking behaviors. So those include whether the mom they ever smoke during pregnancy or how many cigarettes they use every day. The control variables we considered are 5-year age bins interacted with race and ethnicity, which include non-Hispanic whites, non-Hispanic black, and Hispanic. So we express all those age compositions as share of county females ages between 14 and 55-year-old, which is the reproductive age. We also include indicators for ACA Medicaid expansion and recreational marijuana legalizations because studies have shown they can affect birth outcomes. So this is the empirical framework we are using. We are using this difference in difference framework, and we are using the Kelvin-Santana DID estimator. So again, this estimator are going to estimate cohort-specific treatment effect first. So basically, the treatment effect for each single state, and then you aggregate them, and by eliminating all the forbidden comparisons. So we start presenting some results. We start from descriptive findings. So here we have trend plots for preterm birth rate per 100 live births. So we're trying to see if there are any pre-trends. And also we want to see if there are any divergence in trend after the enactment of the policy. Here, the black line or the black curve give you the control states, the 14 never treated states. And then the other colored lines, they give you states with any policy during the study periods. So from the figure, we don't see any clear trends. And also, these seem quite parallel. Another observation from the figure is you can see states that have ever adopted any e-cigarette policy, they tend to have lower preterm birth rate, which means they usually have better birth outcomes. All right, so the second figure I show you here is for the low birth weight rate. So again, we have a similar observation. We see a strong seasonal trend, but fortunately, this seasonal pattern is very consistent between the control state and the treatment state. And in a DID design, this kind of synergy will be canceled off when we control for Coulter-Lee fixed effects. And then we move on to very low birth weight and infant mortality. The pattern is very similar. Again, we observe parallel trends. At the same time, we don't have any evidence of divergence in birth outcomes. So all of those are average birth outcomes at the county and culture level. And the last figure is for infant mortality rate. So we see there is a decline in infant mortality rate since 2005. And then again, we don't see any divergence in trend. All right, and then we present our formal ATT, average treatment effect estimates. So overall, we don't find any significant effect associated with any loss on any birth outcomes. So for example, here we have panel A, we're analyzing the effects of e-cigarette tax, and then in panel B, we analyze the effect of e-cigarette retail licensure loss. And then in columns 1 through 4, we have different birth outcomes. The first outcome, the outcome labeled ATT, they give you the treatment effect of that policy on a specific outcome. So if I add one significant star, it means it is significant at 10% significance level. However, we don't observe any significant star here. And also the magnitude of any estimates of any coefficient, they are very close to 0. So overall, our conclusion or preliminary conclusion is we don't observe any effect on birth outcomes associated with e-cigarette taxes or retail licensure loss. And then we move on to minimum age restrictions and indoor vaping restrictions. Again, we don't observe any significant finding of any law on any birth outcomes. And also the coefficients, they are not statistically significant. They are also very close to 0. And then, so we present some event study plots here. So from the CSDID event study plots, you can see two colors. The blue color, they give you the pre-treatment period. So you want to see those are null effects, which shows you evidence of no pre-existing trends. And then the red color bars, they give you the treatment effect or dynamic treatment effect after the enactment of the policy. So again, the overall observation is we don't see a very clear pattern of any effect associated with birth outcomes. And here, different slides gives you, we organize them by birth outcomes. So for example, the first slide is for preterm birth. And then we move on to the next page. This is the effect on low birth weight rate. And then the next slide is on very low birth weight rate. And then the last one is for infant mortality. Although for certain outcomes, we do observe maybe some effects in one period of time, but maybe those are from some outliers, which we're still working on. We're still trying to identify what causes those maybe outliers. But maybe after removing them, the overall pattern, you can see there is no significant findings. So we draw the conclusion. So in summary, so our paper, we use first policy timing with truncated window to analyze the effect of different state policies on preterm birth rate, on preterm low birth weight, very low birth weight, and infant mortality rate. And we find small and statistically indistinguishable from 0 effect associated with any policies. So the interpretation of the finding is Despite policy impacts on nicotine behavior seen elsewhere and seen in previous studies, we do not detect any short-run improvement or worsened effect on birth outcomes. However, we want to say that all the effects so far are still preliminary. So after we addressed some key issues, maybe with the outliers, and then we're going to also try subgroup analysis, maybe we're going to find some other findings. And that's all for my presentation. Thank you so much. I'm going to open the floor to discussion.
Wonderful. Thank you so much. So again, we'll turn to our discussant first.
Great. Thanks for that presentation. So I have a series of comments, mostly making sense of the null result here, the no effect result. Um, yeah, so all of these policies that you're analyzing in one way or another, we think they increase the cost of using e-cigarettes. Right? Maybe not the direct monetary cost, but they might affect norms or things like that. Um, and my main thought is just that substituting one form of nicotine for another might cancel out to no net effect on birth outcomes. So, if we think nicotine is the primary harmful component for the development of the baby, then maybe there is substitution going on, but it's roughly the same amount of nicotine, and that cancels out to no effect on birth outcomes, which makes me wonder if you might want to look at cigarette smoking as an outcome, because I know that is in the birth records data. So did you
Yeah.
consider that?
Yes, that's a very good point. Actually, we already have the result, so it's not in the slide. So for now, we do observe a substitution effect, but for most of
Hmm.
the policies, that substitution is insignificant. I remember we only observed one significant finding for, I can't remember what policy is that, so I'm not going to give an uncertain answer. So we do
Okay,
observe one significant substitution associated with one policy, but for the other policies, the effects are positive but insignificant.
I see.
So I know in the previous literature, usually people only consider a subset of states because some states, the revision of the birth outcome they changed at around 2010. So we are still considering maybe limit the states into that subgroup that can give us maybe a better first stage effect.
I see. And my next comment is that I think one of the channels is completely shut off. One of the channels where we think these policies affect behavior is anti-nicotine or anti-tobacco norms, because pregnant women are this unique population where there's already strong norms against using nicotine at all. So now if you tell them that you can't use an e-cigarette inside, that might have no effect. They're already not going to use it inside when other people are there.
Yeah.
So just the thought about one of the channels might not even be functioning here, although there are other channels that work.
Yeah, that's true. So maybe the effect on norms and perception, if there are already tobacco policies in effect, then maybe this added value is very small and negligible.
Yeah,
So I feel so when we read up the paper, we're going to include a very detailed discussion of this channel. So whether we should consider it or not. But for now, we are analyzing maybe an overall effect. So this is
right.
a reduced form overall effect of all the e-cigarette policies.
Yeah. And my next thought was about infant mortality,
Mhm.
because in our similar research, we did find an effect on infant mortality of indoor vaping bans,
Yeah,
but the effect was strongest later in the infant's life. So we found a stronger effect in the 100-day to 1 year range, which might make sense if there's more exposure to secondhand smoke as opposed to secondhand vapor, which would
yeah,
probably be weaker. And then that could cause respiratory problems in a marginal case where the baby's health is already poor.
yeah.
So the idea there is maybe look at infant mortality, but later in the first year.
Yeah, that's actually another very good point. So for now, we are considering 12 quarters after the policy. So that's 3 years post policy. But we can definitely extend that post-period window and see if there are any long-term effects. And actually, from the figure, like the effect of e-cigarette tax and retail licensure law, we can already see there can be some effect in the long run.
Mm.
But so far, we don't see any effect for indoor vaping restrictions. But again, for the last period, so if you look at panel D, the last period is turning negative. So maybe after we extend the post period, we can
Mm.
observe something.
Yeah,
But
that's a good point. You can kind of already see no effect in these uh, event studies.
yeah,
Well,
so
well, the outcome here is just death in the first year, right?
yes, that's right.
Yeah.
Yeah, and
Okay.
actually, I do review that paper, and then actually, the main difference is the sample. So maybe, like I said, maybe when we subset to a cleaner subsample, we can get some effect. For now, we are considering all 50 states and DC.
Yeah. And I just have two more comments. The next one is about local level laws. You only look at state level laws.
Yeah,
Um, and in our research, we bought data on county and city level laws because there are a lot of big counties and cities that implement these e-cigarette restrictions before it goes statewide. And I'm pretty sure that could lead to attenuation bias and bias your estimates towards zero because a big part of the population is getting treated before uh, it's coded as treated in
yeah.
your data. So
That's
that could be one thing that's happening.
Yeah, this is another very good point. So actually, we already started analyzing county level policies, but unfortunately, we don't have that data set you use. So for indoor vaping restrictions, we realized there are many counties that have their own policies. But for tags, we looked into so the counties data set. So there are two big counties maybe we want to consider. That's the next step. And then also for retail licensure laws and minimum legal sales age, there are a couple of counties, but only a handful of counties. So we can easily just include them in our sample. But for indoor vaping restriction, there are so many counties.
Yeah,
So maybe I will reach out to you
sure.
to identify the effect at the county level.
Yeah. Okay, and my last comment is I just have this sense that maybe these policies only bite when they're put together. And maybe you can construct some outcome measure that's like the policy intensity or the policy count. Because we talked about it earlier when we paused for questions that um, once these states are getting to the strongest regulatory environment, they get truncated out of the sample. So
Yeah.
maybe there's kind of a building effect of having all four policies that you're not seeing with your current identification strategy.
Yeah, exactly. So when we analyze multiple policies, maybe also going to extend our study window. We're going to extend the data to 2024, where all states, they already have this tobacco 21 law in effect. And then we can construct some intensity measure to analyze what is the effect of two policies, three policies, and four policies. We can either just look at the numbers or we can look at maybe the policy combinations. That can be a follow-up step.
Yeah, that's great. That'll be really interesting. Those are all the comments I had prepared. Thanks a lot for a really interesting presentation.
Thank you so much, Michael.
Thank you so much. So please do keep your questions coming through. We have a question from Mike Pesco. Would cigarette taxes be a useful control, for example, indoor air laws affecting smoking?
Yes, so actually in your previous version of the paper, we already controlled for tobacco taxes. But then for this result, we haven't controlled for that tobacco tax. But from our experience, controlling for tobacco tax or not doesn't really change the overall findings.
Thank you. And I'm just looking at some of the questions that have already been answered in our Q&A in case they're interested for us to hear and for you to consider as well. In particular, the last one that came through from Mia Pang said the regulations had no effects on birth outcomes. Do you think this is because the prevalence of e-cigarette use in pregnant people is too low to observe an effect? And Andy shared that low prevalence is likely part of the explanation, given that very few pregnant people use e-cigarettes. I wonder if you have anything you might want to add to that in thinking through the reasons here?
So again, our next step is to do some subsample analysis because we have birth certificate, so we can see what's the impact on maybe the youth or young adults. So we're going to release that result later.
We look forward to seeing that. And Mike's shared just some information that county level indoor vaping restriction data is now available through a policy data repository. So that is in the chat for anyone who might be interested in looking at that. Thank you for sharing that, Mike. We also have a question from Sherry Warshaw. It might be interesting to also track incidents of cleft palate with e-cigarettes versus conventional cigarettes, she said.
Um, So, uh, yeah, that's very likely. So actually, I have already started to consider that. So we're going to consider how e-cigarette policy interact with tobacco policies, but then it will make our identification even more challenging. We are already truncating the windows, and then if we consider tobacco policy, then uh, I wonder if we have enough power to identify any effects. So there's a trade-off in terms of identification versus do we consider all the policies? But maybe a very easy way to implement that idea is to control for any tobacco policies. We're going to just use dummy variables. Yeah, but that's a very good suggestion.
Great. Thank you so much. Okay, unless any more questions are coming in, I am going to suggest that we close out because we're very lucky that Ben is available for top of the top. So if you have more questions, keep them coming through Q&A. But if you'd like to discuss with the speaker directly with Mike's enabled, you're more than welcome to attend Top of the Tops immediately following this webinar. If you're interested, there's going to be a meeting room URL posted in the chat. And if you copy that, you will be ready to join the live discussions once this webinar concludes. Oh, I have something in the Q&A. Let me just pull it up. Oh, I have a thank you very much in the Q&A. So thank you very much. And I will hand over now back to our MC, but thanks so much.
Thanks.
We are out of time. However, if you still have burning questions or talks for Dr. Ben, please join us at the top of the tops. That will be an interactive group discussion. To join us, please copy the Zoom meeting URL post in the chat and switch rooms with us once the event concludes. And we will leave the webinar room open for an extra minutes after the end and give everyone time to copy the URL. Thank you to our presenter, moderator, and discussant. And finally, thank you to you all for the audience of 126 people for your participation. Have a great weekend.